today for. Highly appreciate it. So today I will talk a little bit about THETA for the people that don't know us very well, what we do. I will talk a little bit about complex intervention as an introduction in our work, and then I will focus more on the complex intervention done by THETA. So THETA Collaborative is a multidisciplinary research collaborative established in 2007. We are funded by HQO, and we've recently been renewed with another 3-year funding. We have 3 divisions. I know the initial thought is when you talk about THETA to think about modeling and health economic divisions. However, we have 2 other divisions, which is clinical research division, which I'm very proud to lead, and we have health policy and ethics division, which is led by Dr. Fiona Miller. So we have a lot of investigators and collaborators as well as staff, and we did a little exercise for our renewal grant, and we calculated the return on investment on THETA. For every dollar that ministry invested in us, they got back 2.5, so pretty decent return on investment. So we have different areas of expertise. First is evaluation of complex intervention. We do community-based research as well with field evaluation and clinical trials using mixed methods, quantitative and qualitative. We do economic evaluations and ethics and health policy research as well. These are our partners. So now I will focus more on a complex intervention, and basically what is complex intervention? Most of the time when we ask a research question, we use a PICO form, which stands for population intervention comparison and outcomes. But when we talk about complex intervention, we need to go a bit beyond PICO research questions. So they develop PICOT and PICO-TS, T standing for time of the intervention/trial, and S standing for setting. Very important piece for complex intervention is context. It's usually said that complex intervention are context dependent. But what do we mean when we say context? I found these 2 definitions that I kind of really like. First one is Webster definition, interrelated conditions in which something occurs. And the other one is that it's social, economical, political, and organizational characteristics of the setting in which interventions take place. So as I mentioned, complex intervention. With complex intervention, we need to go beyond the PICO question. We do have to take into account context. But then there is a question, how do we assess the context, the effect of context in the intervention? We have to think about processes of implementation of intervention, but how do we collect any information? Theory that basically underlie the pathway between the intervention and the outcomes. What's very important with a complex intervention is that complex interventions usually answer not only if something works, like what works, yes or no, but also how and why. Certain characteristics are affiliated with a complex intervention. Basically, complex interventions usually have number of interacting components. They have behaviors that are also interrelated with the intervention being received. They have different number of groups or organizational levels that are usually targeted at intervention. So intervention may be delivered to patients, but there is also effect at the higher level. That is, usually they come with a different number of outcomes, and there is a certain flexibility in tailoring this intervention that intervention permits to capture the context factor. So talking about development and evaluation process for complex intervention, ideally we should know how the intervention caused the change, so that good understanding. Also think about that sometimes lack of the effect of intervention may not be caused by intervention per se. It may reflect implementation issues, uptake process. That's why it's strongly recommended to always nest a process evaluation within the trial of the complex intervention as well. There is a certain variability in individual level outcomes that also reflects higher level processes involved. And sample size sometimes may need to be larger to basically account for this extra variability. Single primary outcome may not be the best use of data. That's why sometimes they recommend multiple primary outcomes. And also, strict standardization across the sites may not always be the most appropriate. Sometimes intervention may work better if there is a specific degree of adaptation. That's why we have some pragmatic randomized trials to account for that. So this is a kind of a framework developed by the Medical Research Council, revised one in 2008, basically showing that all these processes are taking place, like there is no linearity, that all these processes may be taking place at the same time and affecting, basically feeding each other. So development, you have feasibility and piloting, even just to tease out certain implementation challenges. Then evaluation may be happening at the same time, and then large scale up of the implementation. So these are some of the experimental designs that are recommended. Individually randomized trials may not always be the best. Cluster randomized trials they recommend, step wedge designs, preference trial, and randomized consent designs. And for certain conditions, they recommend end of one design or end of one trial. Another key thing which came up in recent, since 2008, is actually, are we talking about complex interventions or complex systems? Sometimes intervention may be simple, but it's implemented in a complex system. So when we talk about complex systems, there are a couple of things to think about. Usually those systems are adaptive to changes in its local environment. That's an important piece. They behave in non-linear fashion, so there is a lot of loops and feedback between the different parts. They are usually composed of other complex systems within, and they may jump from one state to another in, again, non-linear fashion. Outcomes cannot be usually easily predicted. So another key thing that comes up since 2008 and more recently from 2010 with a couple of health economists, they pointed out that basically different dimension of complexity of certain interventions and certain system challenges cannot be answered by existing economic evaluation methods. They call for advancing economic evaluation methods, because sometimes even like explaining differential cost effectiveness across the different context pieces is often speculative. So there is a need to develop a new methods of economic evaluation of complex intervention and complex systems. Now I will focus a little bit about our studies that we have done. Some of those, most of those were complex, either complex interventions or interventions implemented in a complex system. First was TURN study, which stands for Turning for Ulcer Reduction Study. It was multi-site, single-blinded RCT with economic evaluation piece built in to determine the optimal frequency of turning patients, repositioning long-term care facility patients with a moderate or high risk for developing pressure ulcers that are cared for on density foam mattresses, and also estimate economic consequences for Ontario of changing the recommended practice. Recommended practice in the guidelines is currently to turn patients every 2 hours. And in this randomized controlled trial, we look 3 hours, turning patients every 3 hours, 4 hours. Patients were older than 65. They were, as I mentioned, moderate at high risk of developing pressure ulcer based on Braden scale. And we had 20 US long-term care facility sites and 7 in Canada. And the data were collected for 3 weeks after randomization. Some of the key results were that basically turning patients every 3 to 4 hours didn't increase. They actually increased the sleep, increased the quality of life, decreased the staff injury, saved time for other activities, and didn't appear to put residents in greater risks for developing a pressure ulcer. So when you think about this intervention, you would think it's a simple one. We are just testing if the patients were turned at certain time intervals. However, there were other components of this intervention. Patients had to be watchfully monitored for the pressure ulcer development, and then they developed a checklist. So there were different pieces, and also context piece was very variable between the long-term care facilities. We are talking about even two big jurisdictions, US and Canada as well. Another study that we did was a pressure ulcer, multidisciplinary teams via telemedicine or PUMP study. It was a cluster pragmatic step wedge design, RCT. It had a strong qualitative component done by Sylvia, which had ethnographic observation and in-depth interviews, and it had also economic evaluation. I want to say that all our studies, we build in always economic evaluation as a key phase, key part of every trial we do. And the primary objective was to evaluate if basically evidence-based multidisciplinary team increased the rate of pressure ulcer healing relative to usual care. And we did that by measuring the wound surface area over the time. The key intervention was a mentorship that facilities, 4 to 14 months of mentorship that facilities received from advanced practitioners with a specific training in wound care. And she communicated with the other nursing team with the email, phone, and video link. We had 12 long-term care facilities in Ontario that enrolled 137 residents over the period of 17 months. And unfortunately, we didn't show that actually multidisciplinary teams did not improve the rate of healing of pressure ulcer in long-term facilities. However, again, a key piece in this study was a qualitative piece that identified certain barriers to provision of optimal wound care. High-level turnover, poor organization of the wound care delivery in some setting, and again, there was a huge effect of the context piece because 6 of those long-term care facilities actually did quite well, like 4 to 6, and then with others, we found the significant issues. A next study that we are doing, again, is a team of the wound. It's, again, wound interdisciplinary team where we are community-based. This is now community-based, not long-term care, looking into effect of referral to multidisciplinary team. We are looking clinical and cost effectiveness and of patients that are newly referred to Toronto Central CCAC for the wound management. We have finished enrollment. We had 451 patients that with 532 wounds, and currently analyses are in the process. So we will report on that in the future. Next study that we are about to start doing is to look at the different models and cost effectiveness of pre-operative care in Ontario. It's a mixed method study that will be divided in 4 phases to identify existing Ontario pre-op care clinics, describe the current service models in identified clinics, also describe the practice care patterns and patient management in prospective cohort study of 1,000 patients, and look cost effectiveness analysis. Again, it will provide not only environmental scan of the province, but also see differences in care and how settings affect that. Some of these clinics are affiliated with hospitals and some are community-based as well, or primary care physician-based. So our other set of trials that we do is MARS Excite. MARS Excite stands for Excellence in Clinical Innovation and Technology Evaluation. It's a collaboration between MARS, between the Ministry of Innovation and industry, and actually it aims to bring certain health technologies early in the process of evaluation. Usually health technologies are evaluated once they are in a marketplace. This one, the goal is to bring evaluation to the pre-marketplace. So it's pretty innovative. Ontario is pretty unique in doing that. Quebec is doing something to a smaller extent. So we are happy to be one of the methodological centers involved. Other methodological centers are PATH, ARC from St. Mike's, Ottawa Method Center, and different methodological centers that are focused on particular pieces, such as UHN Humanera. They are looking usability studies, like how usable new technology is for the patients or healthcare providers, depending who will use the technology. Some of the studies that we are doing right now is a home sleep study with apnea DX for diagnosis and management of obstructive sleep apnea. We are looking, it's a pragmatic multi-center randomized controlled trial. We are looking effectiveness of management of obstructive sleep apnea after being diagnosed with either standard of care, which is polysomnography, or apnea DX portable monitor. And we launched the study this week. So this is the basic diagram of the protocol and randomization. The next study that we have is looking into tumor RNA disruption assay as a predictive tool for early response to neoadjuvant therapy for the breast cancer. Again, this is a mixed method with a 3-phase. It's a cohort study. We will look into association between tumor RDA score and predictability, basically, of pathologically complete response using fine needle aspiration biopsies. And there is also economic piece that will look cost effectiveness. Then this is something that is coming right in progress, so I wouldn't necessarily elaborate a lot about it. It's just to look at home hemodialysis system, where we will have 3 key studies. First is prospective multi-center randomized controlled trial to evaluate clinical effectiveness, safety, and efficacy of the new home hemodialysis system. Phase 2 is adoption study that will be done by Dr. Fiona Miller and her group, looking comparative case study of the device uptake and also comparative study of policy context across Canadian jurisdictions and internationally. And phase 3 will be a patient values and preference studies. Other projects that we have, it's one of the is investigating stroke unit care. To look effectiveness and cost effectiveness of stroke unit care provided in Ontario. Again, it's one of the examples that actually, when you read all the description about complex intervention, one of the examples that they always put up is basically stroke units and differences in care they provide and how it is context dependent where they are as well. And then we have a MedCheck, clinical and cost effectiveness evaluation, a mixed method study. Again, complex. It's a complex from the point of view of the complex system where it's set up as well. This is a project map. And this is the study that I want to talk a little bit more about it, which is program evaluation of telehome care for patients with heart failure or COPD. We call it telecare study. It's funded by ministry. It has 2 phases. Phase 1 is a program evaluation, and phase 2 is intervention evaluation. It will evaluate how various models of telehome care that are currently offered to people in Ontario with heart failure or COPD are implemented and how they impact patients, family caregivers, and health system outcomes. So this is just a brief introduction about the problem that COPD and heart failure, they impose a significant social and economic burden to patients, families, and healthcare systems. COPD is the 4th leading cause of death, and heart failure affects approximately 500,000 of Canadians, and it does come with a high mortality over the longer course of like 10 years, and cost is also considerable. There were some initial studies pointing out that telehome care, different telehome care intervention might be effective in increasing quality of life and self-management of patients with COPD and heart failure. However, results were not conclusive, and there is also lack of cost-effectiveness research. And since there is a telehome care program already introduced in our province, and we expect that patient recruitment rate of 30,000 by 2015, that's a prediction coming from ministry. it is very important to do multi-level evaluation of clinical and cost effectiveness of this program. So this intervention, telehome care intervention, consists of telehome care nurses with whom patients interact by phone Monday to Friday, 9 to 5, over the course of 6 months. They transmit their data on blood pressure, on weight, on blood oxygen saturation on a regular basis. They communicate with the nurse daily. If alarms are triggered, nurse is calling the patient, and there is also weekly consultation to discuss their health goals. So this is how it was implemented so far in 3 steps. So initially, the whole point was for us to do the evaluation of the intervention, and this was proposed like 2 years ago. Basically, we wanted to do a match cohort study using ICE data to do a retrospective propensity match analysis, descriptive study to look the patterns of use for telehome care, and qualitative study to see the experiences of patients. However, in the middle of their implementation, their patients started to drop out early in the intervention. They identified issues with the technology per se, with patients not being technology savvy. So software program was not very user-friendly for technology, a little bit challenged population. So then they came back to us and say, okay, we want you to look about this implementation piece, because intervention, we can't even have patients finish the intervention of 6 months planned intervention. So then when we went back and designed a program/process evaluation that will explore different implementation strategies of the Ontario telehome care in the 3 LINs. Unfortunately, this intervention is already being employed in 3 LINs: Toronto Central, Central West, and Northeast. So what we are going to use, we are just about to start, is multi-level frame to assess processes within and between different levels, different system levels. So macro at the level of the LIN, meso, telehome care host agencies, service provider agencies, and micro level like processes between clinicians, patients, informal caregivers. Because we and ministry need to gain insight into implementation of this intervention in Ontario. So primary objective is to explore organizational factors, facilitators and barriers, processes that facilitate or impede adoption and implementation of telehome care across the 3 LINs. They already came up with what they think might be their critical success factors. However, they gave us the list. However, it will be after our qualitative piece and study that we want to do is basically that we will have to go back and redefine those critical success factors and see what appear to be the most responsible for success of the implementation. Secondary objectives, we will look how various models of telehome care enable patient self-management, impact patient outcomes. So there will be a piece. This phase will primarily focus on process outcomes, but there will be also patient outcomes as well and system outcomes that we will look for. Study has 3 components that again combines 2 research methods, qualitative and quantitative. There will be a comparative case study, descriptive study, and ICE data linkage. Comparative case study with the in-depth interviews and observations. And basically, each LIN will be case study on its own. Quantitative study will actually look into patterns of use of telehome care. We will use data captured by Ontario Telenetwork. And we will also conduct surveys with the providers and patients as well. And ICE data linkage, we will look for healthcare service utilization and costs. So these are the surveys that we want to use to give to our for patients and healthcare providers. Study population has been defined before with the telehome care program per se, but we did help define that population. We worked with the ministry and with the Ontario Telenetwork to define it. Basically, we will use patients who are diagnosed with heart failure or COPD, and they have to be a heavy user of the healthcare system. They have to be able to provide consent, speak English, and operate equipment. They have to live in a residential area, either long-term, like a retirement home or private home with an active landline, and they have to agree for this evaluation. And these are inclusion criteria for the healthcare providers, which are very simple. Basically, they have to consent to be part of the study and be interviewed. Primary outcome is to identify organizational factors, facilitators and barriers, and processes. And we have a whole list of the secondary outcomes to look into patterns of use of the telephone care, experiences of the healthcare providers, of patients with various models and implementation models, integration of care, and also looking at the costs and outcomes for the other outcomes for the patients. And so far, with respect to implementation, the first piece, the qualitative, we have ethnographic field work, we have semi-structured interviews, and also we have documentary sources that we are going to use to see how it's being implemented, what are the processes at each link. And so far, we've been submitting REVs like crazy. Nida and her teams will submit approximately 30 REVs. We already did, I think, around 10. And once REV approvals are obtained, we'll launch the evaluation piece. So as I mentioned, the first phase is a program evaluation / process evaluation. And then phase 2 from October till end of December 2017 will be intervention evaluation that will use the original design with the propensity score matching. That's it. Thank you. Okay, Mari has questions.
Can you tell the story of the telephone care and explain why this is particularly needed, why a complex particularly needed? Because this is, I mean, it's a really, I can't tell the story all I can, because it's a really, I didn't know what a complex. This is like a classic example of why you need something like this rather than just a straightforward random.
Okay, so basically, again, since we have a very strong context piece here, we have a patient with a chronic condition that needs to be monitored with the telephone care system. But then there is also integration piece that needs to happen with their primary care provider and other providers of patient care. That's why it's a complex system that you can't actually, you have to look different factors, which not only intervention per se, but how that intervention is nested in the current healthcare system. And I think that the previous study in UK showed that actually that integration with other pieces of healthcare system are crucial for this intervention to work. They did implementation across 3 jurisdictions in UK, and in one jurisdiction it worked like a charm. Why? Because it was really very well implemented with the community care, with long-term care if it was needed, with a primary care group, and with a specialist as well. And I think what's happening here and why it's not working is that that integration never truly happened. So for example, patients are taking care from 9 to 5, but after 5 and over the weekend, they go to emerge. So there is no, there has never been that integration done. And I think that will be the piece that will need to be set in, but that goes to the higher level, that goes to the, not only to the level of organization, let's say where we have, who is adopting telephone care, like telephone care agencies at hospital, but level of the policy and system per se, because certain policy changes will, I think, need to be in place for this to work and that integration to happen. And right now, I'm not sure that it's there. Well, I'm pretty sure it's not. So I hope that answers your question, at least partially.
Does. I mean, so I'll just say one or two things. So we started this 2 years ago, and we wrote up this very nice protocol for randomized trial.
Yeah.
We thought, okay, pragmatic randomized trial, that's the most obvious way of evaluating something like this. And we tried to get this going, and then the ministry said, we haven't really rolled it out very well.
Exactly.
And also, it's different in every LIN. Like we're doing recruitment, different kinds of patients in. And actually, we haven't really thought about the doctors as part of this very much. This is from a nursing perspective. So there were all these, so it was like a really not a completely developed intervention. So the ministry was appropriately a little bit cautious about trying to launch a very large, robust, definitive evaluation. So then we backed off and we said, okay, well, we'll do an ISIS analysis. That's not, it's not a randomized trial, so people won't. But then even that, it looked as though they hadn't really developed and fully understood how the interpretation work, what the information was going to be gathered, how it was going to be acted on, even the conceptual model of how this works. Like the ministry thought this was meant to actually work by teaching people how to manage their own. But it's not clear that that's how this works. It may very well be that the actual ongoing monitoring, so the model hadn't really been worked out and it hadn't been, group levels were really low. So we couldn't really even begin to evaluate the implementation.
And patients were dropping out like crazy. Like dropout rate was so high.
So many complicated pieces getting the intervention right, and as you said, getting the intervention as it links with all the components of the health system, developing a theoretical model of how it works. All of that was really necessary to understand the intervention and then to try to develop evaluation.
Hi, I'd just like you, if you possibly please, to talk a little bit about the indicator development and the selection, because I know that you've talked about the macro, the meso, and micro level, all those different things, and then the complexity of the system. And you see that if you're trying to even talk about the mechanisms underlying the behaviours, how did you arrive at the indicators that you arrived at? Was it a process theoretically driven? Was it driven by goals of the ministry? And how was that kind of negotiated to land with a realistic number of key indicators?
So basically, indicators are not fully like confirmed yet. So it's a draft indicators. Came from the theoretical piece, reading other people's experience, and also talking and taking into consideration previous LIN's experiences so far. So it's kind of, we drafted the indicators. We will need to confirm them now with the study. Once we go there, they will be fully defined. And what we are also trying to do, basically see how we can capture those thoroughly and then give the tools to different LINs to capture that on a continuous basis. Because one thing is a wish list, but one thing is what's not feasible. So there are steps actually. Recently we've discussed with ministry about that, because that was my suggestion from the beginning pretty much, is just we need to make sure that we define them properly as well. That's the first step. And then give them tools to capture and make it more sustainable for them to capture over the long period of time and evaluate, because only then it will be useful for them, because just even developing, what are we going to do with them, right?
So in terms of the evaluation, it essentially is developmental.
Yes, exactly. So that's, again, like now we are really trying to be very cautious and try to cover all possible angles as much as we can, because they had a previous experience, that we need to kind of address as well.
Hi, Bob. We like the presentation.
Thank you.
And I'm here because I want to learn more. But out of curiosity, I didn't look at the timeline slide. In your phase 1 process evaluation, so you'll identify a lot of barriers, right, happening. And will you try to address that, the ministry address them before you then move into the
Absolutely.
intervention?
Absolutely. It will be iterative process. So even when we define the, let's say, indicators for process indicators, just to make sure that that piece will be nested even in intervention evaluation, because the whole point is to give them feedback and continuous feedback as we come along. It's an iterative process, and it will be in iterative steps. Absolutely.
I have a couple questions on your study and how you came about how you're going to implement it. I'm just very interested in learning about THETA. So you mentioned you have an ethnographic piece, qualitative piece, and quantitative piece. Hold all that in your group, or you outsource across the university, how does that work?
So basically, we have a lot of expertise within our team. I think we are blessed to have 3 divisions now, and if we need to go for and we have a lot of people with exposure to different parts, like quantitative and qualitative experience as well. And we have also some external, like, because we have a big group of investigators. So let's say each division has also external investigators that are not like THETA, but they are affiliated with THETA, so THETA affiliates, and then if we need that expertise to draw upon that, that's also available to us. We usually don't outsource. Sometimes we do, like we have, for example, and Sylvia has been working with us, but I feel about and Sylvia that she's THETA in a way, so it's not really outsourcing. So, but yes, usually because especially now having 3 divisions, so for example, for this study, what I mentioned, home hemodialysis system, there will be a big piece, which is adoption study. But again, it will be done by Dr. Fiona Miller, who is our lead for the 3rd division. So no need for outsourcing. It's in-house. But yes, we love to work with other people, and absolutely, like I think we are very collaborative, and we enjoy working, and we've been working like through Excite with ARC, with other groups as well, and so yes, sometimes it happens, absolutely. Yeah.
How do you account for how long the intervention needs to be, and then how do you account for how long the follow-up needs to be?
Okay, so initial
complex intervention.
For complex intervention, so it depends. It's very hard. With the complex intervention, usually they recommend, if you want to capture outcomes that go beyond the patient level outcome, if you want to capture system level outcome, you need to have a longer term follow-up. Absolutely. However, you have to balance that. So sometimes they say 3 to 5 years, because if you want to see the system change, right, that takes time. You see patient level outcome reasonably soon, or let's say some are more long term, so you need a 1 year follow-up. But like to see system level outcome impact, you need a longer follow-up. However, it's not always easy to run trials for, let's say, 5 years. There are limitations, financial and everything, ethical. So they recommend to use sometimes surrogate outcome for those system level changes that you expect to see. So it's dependent upon the intervention. So I think before designing, basically, once you know what kind of intervention you need for what condition and what you are looking for and what system level changes you may want to see, then it's easier kind of even to pick up those intermediate, like a term outcomes that could be surrogate for your system changes. But sometimes, like there is a very nice piece in the new MRC framework that speaks about follow-up and need for the follow-up. And they say, ideally, again, if you want to see the system level changes, you need a longer term, because that involves policy change and, whole system to change. But there are early signs that could speak to that. So they usually recommend to think about those outcomes. So for example, for our study, patients are on telephone care for 6 months because they want to test like this intervention, how it empowers patients to take a better self-management. So 6 months, and then now they started to think about some kind of, how do they want to develop this model further? Do they want to have it something like not full-time monitoring, but let's say once a month monitoring, something like that will still give patients certain follow-up, but not as rigorous as this first 6 months. So again, it depends on the intervention. It depends on what you are trying to accomplish.
Just on the intervention piece, so you have a nurse that's qualified that's delivering the intervention.
Yes.
And my question is really selfish because I have many of these studies that I'm trying to review systematically. Mm-hmm. How do you account for the intervention cost of the person delivering the intervention, not knowing how much administrative time that they're taking to prepare for each of these interventions? Nothing outside of the methodology is known, right? So how do you account for cost when you go to do it cost effectively?
So basically for this one, because nurse is interacting with patients, we are monitoring when she interacted with patients, how long was each interaction between the patients, how long was each consulting, because there are interactions based on a patient's health condition. If the patient has high blood pressure, she will call the patient. She will say, let's modify your medication, or think about that. So we capture that OTN database, captures that, and then we will cost that.
Okay.
So that's the best thing that when this was whole process designed long time ago, that's what was recommended, and they captured that.
So any preparatory time is, I mean, it's a challenge.
Oh,
I
absolutely.
understand the challenge, but
Yeah.
it's just, you wouldn't account for it or assume that preparatory time is taking place or anything.
So basically, there is a piece for the training time when she's training patients, let's say for 7 days. There is that captured. I'm not sure about the preparatory time because these are more like alert responses. So she can't really prepare for something unknown, right? She can prepare in general what kind of consultation she needs to give every patient, which is again tailored to patient needs. So some patients will need smoking consultation, some will need weight loss consultation. So we can take how long that basically consultation takes place and how much time she spent. But she already have those, like she has those, let's say, documents ready. But these alerts, she can't really prepare because they are triggered by alarms, right? If the patient blood pressure goes up, every case is, personally tailored. So for that one, there is no preparation. She just needs to know the basic guidelines in terms of like clinically, if patient's blood pressure goes high and patient has this condition, then what can we do? Can I do any medication modification myself? Do I need to call the primary care physician? But that's all captured. Like all that interaction is captured. So that's the best we could do so far. But then once we start into intervention evaluation, like furthermore into this, then we can revisit that with our economic group. So, and I'm not sure, like we were like reasonably lucky to have all of that kind of built in. I'm not sure how others are, like how much you can get. Like, yeah, especially if you are doing systematic review.
Oh. Thank you. You're next. A quick question. I was expecting to see a logic model.
Oh, there is a logic model. I just didn't want to.
So.
I didn't want to overwhelm.
Oh, okay. I was wondering.
Yeah, there is. There is. I'm happy to share. I'm happy to share. Again, we look 3-level outcomes: short-term, intermediate term, and long-term outcomes for the phase 1.
So I understand, conceptually when you're planning your process evaluation, it's good to have an idea of all the things that are going to take place. Do you expect to be using it a lot and time goes by to refer to this, or how do you think you're going to use this tool?
Okay, so it depends. I had experience both ways. I developed a logic model to evaluate process of post-arrest care for the grant application, to be quite frank. And we won the money. We started doing the study. We did refer to it a couple of times, but as the whole implementation was going on, it changed. What we proposed modified as well. I mean, it was good. Like we went back a couple of times, but I can tell you that it changed nicely. Like what we proposed in a grant and what we actually had in the end was not exactly the same. So there is that iterative piece. It's always actually informative to see how your research process changes. Like you start with something, and then while you are gathering the data, analyzing the data, you see actually what you are coming to. And that's always interesting. So I think we will be referring to it. Are we going to find exactly the same things what we thought we would? Probably not, like to be honest. So that was my experience with that particular one. And this is even more complex, like post-arrest care. It's very complex. It has like 5 guideline recommended, kind of interventions that every post-arrest care patient has to get in hospital setting. But this one is even, I would say, more complex because there is a huge system level and differences across the lens, while the other one is more focused. Hospitals, yes, we have urban and rural hospital, like university-affiliated community, but it's less diversity than what we expect to see here, I think. So we will see. But yes, we have one as a starting point. We did the due diligence. At least we tried.
Home care is implemented more in the urban areas or outside?
Both, because LINS are Toronto Central, Central West, and Northeast. Northeast has a rural component, right? It's all area around Sudbury, Timmins. So we are going to see now, but like the Toronto Central is, you know, pretty urban area. So it's in both. And we will try to tease out, of course, differences, because we will try to analyze like within each case, like within the case and across the cases, like each case studies, and see the differences, to tease out even what kind of processes you will find, and how actually some outcomes are different. It might work completely differently, and it might affect patients completely differently in between urban and rural areas. It might be more important in rural areas because their access, let's say, to hospitals and to even their primary care provider, it is for sure will be different than if you are, let's say, downtown Toronto. Because I know from other studies, let's say, in chest pain patients, just to go from, let's say, Sudbury rural area to their specialist, it's a 3-hour drive. Access is different. Like physical access is different. It's not even provision, forget provision, access is different. So we may see differential impact of this intervention across. I think, we'll see. That's my speculation.
Just to monitor some can be then patients be born.
Absolutely, absolutely. It's like a more monitoring and consulting, like basically providing consultation based on like a general lifestyle as well. But if there are certain needs that need to be answered, absolutely, they will still be referred to go to a certain specialist. Absolutely. Sometimes nurse will communicate with specialists to check before she sends patients physically. There is that interaction between the telephone care nurse and the specialist. But if there is an urgency or need, absolutely.
The nursing mentioned the centralized or it's different in separate units.
Okay, so what happens? This intervention has monitoring sites where the telephone care nurse sits, nurse or nurses, it depends. Across lines, it might be different. So for example, you may have few monitoring sites in one limb, while let's say for Central West, there is only one central monitoring. So I expect that certain processes will be different as well. While it's like with the Toronto Central, we may see 2 or 3 monitoring. And I know for sure in Northeast, there are a couple of monitoring, right? 5 or 6 she mentioned in different hospitals. So there are differences in limbs, yes, across the limbs. So we'll see how that works as well. Central West is more centralized, one monitoring unit. All patients are monitored from that unit. They have a couple of telehealth care nurses. Again, we will know more about this once we start to do qualitative piece ethnographic observation, talk to them, and yeah.
Okay, this is just a kind of a practical. So does that mean when you're actually trying to interpret the data at the end, you're going to have the 12 information? Are you going to be trying to cluster some of them? So, for example, the cases of men versus women, urban, rural, limb versus that limb, and that type of thing, like that. And my second question is around what I call contamination, where you may have people involved in the study, but yet they may be completely involved in the way. How do you kind of deal with that?
Okay, so basically, if they get the help outside as well, it will be recorded. So, like, it is recorded in the system. If they go and see somebody else, if they get the help from somebody else, a specialist, a primary care physician, it is recorded in the system. So we will be able to adjust for that in analysis piece. And with respect to clustering, again, since this is more focused on the processes, like we will try, but then again, I mean, dependent on the sample size, especially for the quantitative piece, I'm not sure that we will tease out anything strong enough. Like if we, you know, look urban versus rural, look like we will try, but then again, until we see the numbers, right, it's very hard to kind of predict. Ideally, yes, absolutely. It would be great to do subgroup analysis based on rurality, based on different things, even just across the genders, absolutely, but oh, you have
Settings. So I know you're going into one study, and this is very different than the scope that I have, which is a systematic review, but if within LINS there's going to be system differences, the study level, when you're doing a systematic review where you probably are only going to get the country of the RCT, I mean, if you don't have that detail, how much bias is the setting going to introduce?
For sure, it will be some bias, absolutely. Like, I'm not sure how much, because again, like, we are dealing with the primary data versus your systematic review, but I would expect you will have bias, absolutely.
So is it enough bias for me to actually Google the hospital and whether it's in rural or urban areas and make sure that you capture that? Like,
it depends. If you expect your intervention and your outcomes to be different across the settings, right? If what I mentioned with post-arrest care, I applied in hospitals. It's very contained setting, though there are differences between community and university. But each of these hospitals, they strictly follow the guidelines. They're supposed to deliver the same care. So my contamination across settings should be much less than here. Here, I can expect to get more kind of diversity and, like differences in and impact of the setting. So again, it depends on your intervention and if your outcomes will be affected by by the context piece. But if yes, then yeah, for sure, it would be good to tease out those things, I think, like personally. I haven't done systematic review on that, so I really don't know what you will find, but like just thinking about the context piece and how important context piece is, for certain interventions, absolutely. Like to see the, again, outcome impact, yeah.
Last question for me. So given all the challenges, I think like it's huge, like methods, implementation, dealing with the healthcare system, with different partners, I guess accountability, especially if you have the implementation piece still at the beginning. What are your key lessons learned so far? I guess these studies and other studies you have done in the past. Like what to do, what not to do ever.
Well, think about don't do research. I'm joking.
I feel like, as research, you're fairly well expert and trained in dealing with the methodological challenges. I think that's what we know about it. But it sounds like for this type of intervention, there's a whole range of other issues.
Absolutely. Yeah. And you are learning as you come along, like as you do it. Absolutely. And I realize whatever I learn at Rescue, and I learned so much, and I'm so grateful to my postdoc supervisor and the whole team. She really taught me well, like in terms of trials and doing big trials. It's nothing what I had to face at THETA. Like, again, community settings, when you can't even implement the intervention because you have a lack of standardization, you have outcomes that are not captured, you have to change practices, which are always hard. What I would strongly recommend for everybody who plans to do any community or any kind of research challenging settings, go talk to people who are doing it early on. Get them on board. Strongly recommend that with all my heart. Get them on board. Talk to them about feasibility, because what we think as a scientist, as a researchers, like what we want to do and answer all these questions, may not even be feasible to do it. So talk to them. Select appropriate outcomes that it will be easy to capture. Don't end up with a study where you are missing outcome of 30% of primary outcome is missing. Don't do that. Think carefully, plan carefully, get people on board who will actually do your study. Treat them with respect. Have them on board as investigators. You can learn so much. It's about, especially for the community or any challenging study. That's one I learned actually even at Rescue, working with paramedics, because one of my trials was like chest pain patients enrolled in pre-hospital setting, 9,000 patients. But I was very conscious of those feasibility issues. I talked to medics, I talked to base hospital medical directors, what they capture. So my study can be delivered, so I don't have missingness, so I have a good quality data. Talk to people who will do your study. Have them on board early on. Be realistic. Be ready to have some trade-offs between what you want to do as a scientist or researcher, what's feasible. Also ask questions that will be of mutual interest, because that's how you get them on board. talk to them about their research agenda as well. Because even though they may not do research themselves, they still have some interesting questions. And that's actually what Lucine and I have been exploring with long-term care people, with the different community agencies, and Josephine as well, like when we have with the pump study, like there are research agendas that are like, you know, we can find a mutual interest. That's how you get them on board. That's my recommendation. Thank you.
Thank you very much. Thank you everybody for coming. It was a great discussion.
Thank you. Thanks for keeping it so short. So we did have a good discussion. I tried. Unfortunately, we can't get. No, that's not all.